Hey fellow lab rats, this is Rebecca from the Lab Rat YouTube channel. In this lecture video, I'm going to be discussing membrane defects that contribute to hemolytic anemias. All right, let's get started. The membrane of the red blood cell has an outer insoluble bilayer of lipids with integral proteins. This membrane barrier separates the red blood cell ions from the plasma. The membrane layer contains phospholipids, cholesterol, and glycophorins. The peripheral proteins are mainly spectrin and actin and are responsible for the shape of the red blood cell, its structure, and its deformability. This membrane also houses pumps which allow ion transport channels between the plasma and inside of the cell. So let's look at kind of a picture representation of this. So this is the outside of the red blood cell and this is the inside of the red blood cell. These are the bilayers of phospholipid membranes. And so this is going to make up the membrane or the outer portion of the red blood cell. So we have spectrin here, we have actin here, here's myosin, and then these are the channels in and out of the red blood cell. So most of these issues or these disorders that we're going to be talking about today that cause hemolytic anemia are issues with these proteins, these spectrin and actin proteins. Okay, so this lecture is about membrane defects that cause hemolytic anemia. Spherocytosis is one of those disorders. Hereditary spherocytosis is an autosomal dominant inherited disorder, most commonly found in Caucasians. This is mainly caused by deficiencies in spectrin. Because of this deficiency, the red blood cell loses its outer membrane. The skeletal membrane is still intact, but this loss creates a very rigid red blood cell. And recall from our erythrocyte lectures that the red blood cells need to be deformable in order to pass through vessels. So if the red blood cells are rigid, this creates decreased survivability for it. And those cells are then transported to the spleen to be prematurely destroyed. So these are spherocytes. So hopefully you remember that term, as I've talked about these previously in my hematology lectures when talking about MCHC indice. Spherocytes have an increased MCHC, meaning that they're not going to have any central pallor, which is that whitish area in the center of the red blood cell. Spherocytes are called hyperchromic because of that MCHC value. They're also smaller in size than a normal red blood cell, so they have a decreased MCV as well. So patients with hereditary spherocytosis experience anemia because those red cells are rigid and inflexible, so they're destroyed. They're not functional, so they get destroyed. So a decrease of red blood cells equals anemia. So the red cells prematurely lysing open can cause hemoglobin to be released in the plasma because the hemoglobin's in the cell, and if it's breaking open, the hemoglobin's going to be released. So this hemoglobin is broken down into bilirubin. So we'll have an increased level of bilirubin in the blood, which leads to jaundice, which is a yellowish greenish tint to the skin. Extravascular hemolysis is happening in this case. So the abnormal red blood cells are being taken to the spleen to be destroyed. So we're going to have a lot of red blood cells pooling in the spleen, causing it to be enlarged. We're of course going to be seeing spherocytes in the peripheral bloodstream, which have that increased MCHC value. We will also see polychromasia, which are reticulocytes. So these are visible in the bloodstream because the bone marrow is trying to compensate for the red blood cell loss and will try to produce as many red cells as possible and will push them into the peripheral bloodstream. Patients with hereditary spherocytosis will have a positive osmotic fragility test. Spherocytes are more fragile than regular red blood cells, so when put into a hypotonic solution, which is the osmotic fragility test, the spherocytes will lyse, creating a positive test. Patients with hereditary spherocytosis will have a negative DAT, and DAT stands for direct antiglobulin test. DATs are used to test hemolytic anemias to determine if there is an immune or non-immune etiology. So hereditary spherocytosis, there's nothing immune happening with it. It's just a defect in the membrane, so the DAT is going to be negative. Patients with hereditary spherocytosis are frequently asymptomatic, and that's because the bone marrow is able to compensate for the blood cell loss. Children with hereditary spherocytosis can have a hemolytic crisis if they catch something called the human parvovirus B19 virus, which is also known as Fifth's disease. Adult patients may have a higher chance of gallstones due to an increase of bilirubin levels, and in very severe cases, the spleen may need to be removed in these patients. So Fifth's disease, which I mentioned on the previous slide, is a virus, of course, caused by the human parvovirus B19 virus, common in kids from ages 5 to 15. Patients experience a slap cheek rash that spreads to the trunk, arm, and legs with this virus. So this little kid in this photo here has the characteristic Fifth's disease rash. This is a self-limiting virus, and most children recover quickly with no complications, but it does present a larger risk for children who do have hereditary spherocytosis. So these are elliptocytes or ovalocytes. So these are oval to elongated red blood cells. They can look like cigars or can even be egg-shaped. Hereditary elliptocytosis is an autosomal dominant inherited disorder. It mostly causes spectrin and band 4.1 defects, which decrease the deformability of the red blood cell. Most patients with hereditary elliptocytosis are asymptomatic because the bone marrow is able to compensate. There can be varying degrees of hemolysis. Patients can become anemic. Elliptocytes present are obviously present in the peripheral blood stream as well. They can also have increased reticulocytes, which is from the bone marrow trying to compensate by making more red blood cells. And all of the abnormal red cells are going to be destroyed in the spleen, causing it to be enlarged, which may cause the need for that organ to be removed. Hereditary pyropoikilocytosis is an autosomal recessive subgroup of hereditary elliptocytosis. So this is present at birth, mainly affecting those of African American descent. And this causes a mutant spectrin of the red blood cell, causing severe hemolytic anemia. The red cells have marked heat sensitivity and fragment at body temperature. So patients with this disorder will have a blood smear that looks like a patient with severe burn, so lots of schistocytes or fragmented red cells. A removal of the spleen may help patients that have this disorder. So these red cells are called stomatocytes. So they kind of look like they have a slit-like mouth appearance to their central pallor. So this can occur in hereditary stomatocytosis, which is an autosomal dominant inherited disorder. It can cause mild to severe hemolysis and a moderately decreased hemoglobin level. So patients that have this, usually 10 to 50% of their red blood cells will all be stomatocytes. The red cells in patients with hereditary stomatocytosis will have an increased osmotic fragility test, which we have already discussed what that is. And they will also have an increase of both bilirubin and reticulocytes because of the increased lysis of red blood cells and the increased production of red blood cells in the bone marrow. Hereditary xerocytosis is an autosomal dominant disorder that causes a permeability defect in the red blood cells. So this causes the red blood cells to become dehydrated, and they look like the cells on the right-hand side of this slide. You see how the hemoglobin is kind of puddled to one side of the red cell. This is characteristic of xerocytosis. Red cells in this disorder have decreased osmotic fragility due to a large number of target cells that are also present within the blood. In addition to the puddled hemoglobin, red cells, and target cells, stomatocytes and macrocytes can also be seen in the peripheral bloodstream of a patient with hereditary xerocytosis. Not to be confused with echinocytes, acanthocytes are another abnormal red blood cell morphology. These are also referred to as spur cells and look similar to echinocytes. The difference is that acanthocytes have irregular spicules of varying length, and recall that echinocytes have evenly spaced projections. So these can be inherited or acquired. Inherited reason is when patients have something called abetalipoproteinemia. This is an autosomal recessive disease that manifests in infancy and causes decreased cholesterol and triglycerides in the blood. Neurological symptoms also occur when the patients are around 5 to 10 years of age and may progress to a fatal disorder later in life. So abetalipoproteinemia is an inherited disorder that causes acanthocytosis and hemolytic anemia. Patients with severe liver disease and those with excessive cholesterol may also develop acanthocytosis in an acquired setting. Now, the last disorder we're going to be discussing in this lecture is paroxysmal nocturnal hemoglobinuria, also called PNH. PNH is an acquired stem cell disorder that causes an intrinsic issue within the red blood cells, causing hemolysis. The red cell membrane lacks glycolipid, which makes the cell more susceptible to complement activation. PNH patients experience sudden recurring episodes of hemolysis, which can be triggered by stress or infections. Clinically, patients with PNH can have iron deficiency anemia in addition to the hemolytic anemia. They can have kidney issues, blood clots, and be more susceptible to infections. They can also have folic acid or folate deficiencies. Patients with this disorder will have intermittent bouts of hemoglobin present in their urine at nighttime, hence the name nocturnal hemoglobinuria. So hemoglobin present in the urine at nighttime. Patients that have paroxysmal nocturnal hemoglobinuria, of course, will have anemia. The red cells will be lysing prematurely, causing hemoglobin and possibly hemosiderin in the urine. Because the bone marrow is going to be trying to compensate, you can see an increased nucleated red blood cell and reticulocyte in the peripheral bloodstream. Patients will have a negative DAT test because this has a non-immune etiology. There used to be a test called the HAM test that would detect PNH, but the best test now for this disorder, at least at the time of this recording, is immunophenotyping. So PNH patients do not have an anchoring protein called GPI, so the immunophenotyping actually tests for that protein. If the patients do not have GPI, the patient is diagnosed with PNH. Alrighty, so that wraps up our lecture on membrane deficiencies that cause hemolytic anemia. This video helped you, go ahead and give it a like. If you have any questions, feel free to leave them in the comments. I will be happy to answer anything for you. And as always, please subscribe to my channel for more educational laboratory content. Until next time.